Hello, everyone. Welcome to South Asian IBD Alliance's Facebook Live on pregnancy and fertility in IBD and in ostomy and JPouch surgeries. I'm Tina Aswani-Omprakash, a patient advocate living with Crohn's and an ostomy, and I'm proud to welcome our wonderful and fierce panel of women in GI who will be sharing their expertise as physicians and patients on their experiences with fertility and pregnancy. With that, I'd love to introduce our panel. I will start with Dr. Uma Mahadevan, if you don't mind.
Hi, Tina. Thank you for having me. My name's Dr. Uma Mahadevan. I'm a professor of medicine at the University of California, San Francisco. I am the director of the Center for Colitis and Crohn's disease there, and my primary area of research is pregnancy and inflammatory bowel disease.
Thank you so much. And Dr. Shahida Din?
Hi, Tina. Thank you for inviting me. I'm Shahida Din. I'm a consultant gastroenterologist with an IBD interest from Edinburgh in Scotland. I'm also chair of the British Society of Gastroenterology IBD Committee, and my work looks at the complications of disease, but also a focus on, how we manage pregnancy.
Thank you so much. With that, I'd like to welcome Tanya, our patient.
Hi, my name is Tanya, and I'm excited to be here. I was diagnosed, I'm from Chennai, India. I was diagnosed with Crohn's disease in 1999 when I was 16 years old. I have had 2 intestinal resection surgeries, and I am on azathioprine and biologics. My first surgery was in 2009, and the second one was in 2021. I have a 10-year-old son who was born via C-section. I'm excited to be here again.
Thank you, Tanya. And moderating with me today is the wonderful Dr. Sabina Ali, if you don't mind sharing a little bit about yourself.
Thank you for the invitation, and thank you for SAIA to put together this important discussion. I am Dr. Sabina Ali. I'm a professor of pediatrics at University of California, San Francisco, at Vineyard Children's Hospitals.
Thank you, Dr. Sabina. With that, we'll move into our program. We have a jam-packed program in terms of questions and preconception checks, as well as the actual pregnancy, then labor and delivery, and what happens afterwards, as well as an understanding of, how to go about pregnancy with an ostomy or JPouch. So with that, we'd like to start with preconception checks in IBD. And I'll start by asking the doctors a few questions, and feel free to, share any thoughts or ideas you might have. And for the audience, we'd love for you to tune in, ask questions, put comments in. We always welcome all your inputs. So for individuals living with IBD, looking to start a family, what are some important preconception checks that patients and their caregivers should follow? I'd love to ask Dr. Mahadevan, Dr. Shahida Din that question, if you don't mind sharing a little bit.
Sure. So ideally, we want the mother to be in remission going into pregnancy. That's not always possible, but that is the ideal. And we want them to come talk to their doctor when they're ready to consider conception. So it shouldn't be, oh, I'm pregnant, hello, I need an appointment. It should be, I'm thinking about pregnancy at least 6 months in advance so that we can do the checks. And often that is making sure you're in remission, which could be colonoscopy, imaging, ultrasound, calprotectin, and then making sure all your healthcare maintenance is up to date. You're not anemic, your vitamin levels are good. You've been to the gynecologist or obstetrician and had an evaluation, and that your medicines are optimized and that you're on medicines that are appropriate for pregnancy.
Excellent. And Dr. Shahida, any other best practices that you might follow from maybe a European perspective?
Yeah, of course. I was going to say, it's interesting. I try and talk about pregnancy and sex with my patients quite a lot, actually, because I think that we should actually bring it up and give them a chance, to talk to us. And some patients don't necessarily want to talk to them. It's not, relevant for them, but other patients absolutely will want to talk about it. And absolutely what Dr. Mahadevan has suggested is that you would do all those checks. I guess I always try and discuss it maybe in my first consultation with a patient, and that includes patients who come to me from transition. You always have to pick your moment about, how you discuss it and be sympathetic to, where they're coming from and what they think about pregnancy. Because a lot of, one of the sad statistics that I read is that a lot of females or women will choose not to get pregnant because they're so worried about the actual thought of it, the act of it, being pregnant. So it's really sad when you learn that about 1 in 6 women will choose not to get pregnant because of what they hear. So I'm really delighted that we're here today talking about this, and I'm hoping to learn from you all too.
Wonderful. Thank you for sharing that. I think some great points made by both doctors in terms of the different checks, making sure you're in remission, but also, having that conversation about sexuality and intimacy, which is so, so important. Here at SAIA, we've done talks on that in the past, so feel free to check out some of our talks on our website and YouTube. Dr. Ali, I wanted to sort of turn to you. As a pediatric GI, I'm guessing that patients and their families might have questions about preconception for you as well, especially in their teenage years. Any thoughts you might want to share on that?
Yes, I think, thank you for bringing that up. I think it's important, as what has been discussed already. You don't also have to start thinking that I'm getting pregnant or I'm planning to get pregnant now. But with a diagnosis of IBD in your teenage years, I think the first question that always comes up, maybe not by my patient, but by the parent, is, can she get pregnant? So it's important that you don't have to be 21, 22 to see what a GYN, meeting with the GYN or your pediatrician to talk about just overall sexual health, periods, what if I plan to get pregnant, what I need to do prior to that, medications, vitamins. Also important to talk about sexually transmitted diseases. So I think it's important to have that discussion with your adolescent patient, and have an open discussion and be comfortable to have that discussion.
Thank you so much for sharing that. I don't think that's a perspective we hear enough, is have those conversations early. And to just reiterate, healthy mom, healthy baby. So keeping us healthy from our teenage years and getting our IBD into remission can only help the process along. So we are going to do this deep dive into women's health, of course, but I also wanted to ask you all about men's health. A quick sort of question around what men can do to prepare for fertility and for their partners to get pregnant if they themselves have IBD. How does that impact the male's sexual health and their fertility? If Dr. Mahadevan doesn't mind starting with that.
Sure. So for men, it's a little bit easier in the sense that it's not 9 months of pregnancy. It's 5 minutes. And so you have to think about what medications are on during that time. So for the turnover for sperm is 120 days. So if there was a medicine you were concerned about, they would need to be off of it for 120 days prior to attempting conception. But fortunately, all of the medicines we use in inflammatory bowel disease, whether it's the biologics, azathioprine, methotrexate, mesalamine, the small molecules, they are not considered to lead to birth defects based on available evidence. However, they may impact sperm quality. For example, sulfasalazine and methotrexate may impact sperm quality. But one of the biggest things that impacts sperm quality is actually active disease. Sperm are very sensitive. A hot tub can impact sperm quality. Riding a bicycle for 50 miles can impact it. So I think those are the things you would need to think about, is, again, being healthy is important.
I love that. So healthy dad, healthy baby too, right?
Correct. Correct.
I love that. Dr. Shahida, anything you'd like to add to that?
I think that was a perfect sort of answer by Dr. Mahadevan, is that, there's lots of other things that will affect sperm quality. And although our drugs theoretically may have a risk, actually the biggest risk is being unwell with active disease, and that needs to be considered and balanced.
Wonderful. I kind of want to turn to Tanya here from the patient perspective. Going back to that preconception aspect of things. What did you experience living in India in terms of getting ready for your pregnancy? Did you initiate care with the GYN? Do you want to go into a little bit about that?
Yeah, sure, Tina. So, like the doctor said, it was actually my gastroenterologist who recommended that since I was my Crohn's was in remission and I was basically fit. Otherwise, I was actually training for a 10K at that time. So he recommended that, this would be a good time. I was 30, I was married for 5 years. So he said probably a good time for me to consider starting a family. So at least the route in India is you only then go meet a gynecologist. You don't already have checkups with an OB-GYN. So it took us a while to identify a gynecologist who would work with us because I was on azathioprine and I had a history of surgeries. But we finally zeroed in on one. And like Dr. Shahida said, I was very anxious that, given the fact that I was on medication for Crohn's ever since I attained puberty, I wasn't sure if I would conceive. So that was definitely something that was at the back of my mind. I was not sure that conception would be easy. I wasn't sure if I would need fertility treatment or supplements. So my first visit to the gynecologist was a very anxious one. And I asked her if I should start something, I should start treatment. And she said, you know what, our bodies are born to, give birth. So go ahead first and take the exam. And if you fail, then come back and I'll teach you how to pass. But I'm not going to give you a tuition before you even attempt the exam. So I think that was something that really hit home. And we decided to just take a deep breath and enjoy the process of, thinking of starting a family. And that helped us actually quickly conceive, to be relaxed, to conceive easily and quickly. Another thing was that I was fit. I was in remission completely. And I made sure that I continued to stay fit throughout the pregnancy. That helped in good, healthy weight gain. And also I didn't have any other complications. Another strategy that I definitely would recommend for people with IBD is meeting a dietitian. Because my diet was very restrictive given the fact that I had strictures. So a lot of my diet is completely low fiber and very often is just limited to kind of soupy broths. So I was worried about nutritional deficiencies in the fetus once I conceived. So meeting a dietitian who would work with us given my limitations was something that gave me a lot of confidence to ensure that I was eating a very balanced diet. And then periodic checkups. Every time we met my gynecologist, we would check back in with my gastroenterologist to make sure that everything was okay from the IBD section. And I think this is another point, especially in India, our gastroenterologist recommended that I have my delivery or my C-section in a multi-specialty hospital so that there would be interdisciplinary doctors available on call in case of an emergency. I think that's something that is to be considered, especially in India, especially given the fact that I had surgeries.
Excellent, Tanya. Thank you for making those points. The dietitian aspect, making sure your diet is as less restrictive as possible so that you can have the healthy weight gain, and especially in the setting of strictures, even fistulae, et cetera. Very important point. But you're also making a really important additional point, which is having, multi-specialty care available and making sure that there's maybe a surgeon on staff, GI, GYN available for your delivery. Outside the context of India, I think that's a best practice across the world. Dr. Mahadevan, Dr. Din, I do want to ask you a little bit about how it's done in the United States and in Europe as well, if you don't mind shedding a little bit of light on that.
Sure. Dr. Din, do you want to go first? Okay. So, as you know, the United States is highly, highly variable in care. And so you can be in San Francisco and have a colorectal surgeon and a nutritionist and a psychologist and an IBDologist all there helping you through, or you can be 4 or 5 hours north near the Oregon border and maybe there's a midwife and a all-purpose surgeon that is available. So it is problematic. For the patients that we see, we recommend if they have complex IBD that they do have a scheduled delivery at a university. So someone with a JPouch, someone with multiple surgeries. We have all of our patients followed as high risk, so with the maternal fetal medicine specialist. And the MFM may just decide to see them once or twice, give recommendations, or they may follow them depending on what they think their risk is. But that is important as well. As part of a process for the global consensus in pregnancy, which was people from every continent coming together, I learned a lot. In Canada, you don't even get to see an obstetrician until after 24 weeks when the baby is considered viable. Before that, you're with a primary care doctor, even if you have IBD. So you're not even seeing an OB, let alone an MFM. And in different parts of the world, high-risk care has different meanings. And so I think we need to be very cognizant of that. In some states in the United States, there's one MFM for the entire state. So we can't give a blanket recommendation, but what we do say is all women with IBD should be considered as high risk and should be monitored for complications, including complications of labor and delivery, preeclampsia, small for gestational age, etc. So wherever in the world you are, that is the recommendation. And then the more complex your disease, the more the need for specialists.
Thank you for sharing. How about you, Dr. Shahida? Any best practices that you're seeing in your hospital system and within the UK, Europe?
Yeah, so I was going to say that Dr. Mahadevan said is care is variable, and sadly we see that too. You know, care is variable. It's sadly a postcode lottery, isn't it, as to what services you have available, and that does impact on our patients. But I absolutely agree that somebody who has IBD has had previous surgeries, complicated disease, a number of drug therapies. They should be being seen or considered as high risk and being seen, by an obstetrician and a gastroenterologist, and potentially even a surgeon involved, in their care to sort of plan that time around, how the pregnancy progresses and what the delivery mode might be. I guess in the UK, pregnancy care is mostly delivered by midwives in the community. And then most people will meet, an obstetrician usually after the first trimester. But we try and have a connection, with the obstetric team locally early on if we know that somebody, is just, the fact that somebody has had such a difficult time getting pregnant. You want to try and support them and, be able to support that process for them. So it's really important to be able to connect and have that network to be able to work with, but sadly, care is variable. And global consensuses are really important to try and help drive up that in different areas.
Wonderful. And I will
Thank
add that patients with IBD should not do home birth.
Yeah. Okay.
I mean, it sounds obvious, but it comes up all the time.
I think that's a very, very important point to be making. Just in general, here in New York, what I've been advised is if I were to go through this, the surgeon absolutely has to be in the room. I need to be working with maternal fetal medicine from the very beginning and make sure my GI is looped into everything that happens. So I think making sure that there's coordinated care for you, especially in more complex cases of IBD, makes a lot of sense. Thank you all for sharing. Dr. Ali, I wanted to sort of hand this off to you now in terms of discussing pregnancy and medications, if you don't mind.
Yes, so I think we had really important discussion already, but now if one of our patients is pregnant or is at a point saying, I would like to get pregnant and go, it's a two-part question for Dr. Mahadevan and Dr. Danis. Medications, what medications are safe to take during pregnancy? How do you counsel the patients? Anything that I need to ask my patients to stop or at a certain point? Any vaccines they have to make sure they are up to date? And if they, as you had mentioned, we would like the best places that we are not in a flare, or if flare happens during pregnancy, use of steroids, is that safe?
Okay. That's a whole lot of questions in one. I will start with the medications. So in general, almost all IBD medications can be continued throughout pregnancy without stopping and throughout lactation. The ones that are the exception are methotrexate, which can cause birth defects and miscarriage. That should be stopped at least 1 month, ideally 3 months prior to attempting conception. Azathioprine, 5-ASAs can all be continued through pregnancy. If you're on sulfasalazine, you should double your folic acid to 2 milligrams daily instead of 1 milligram daily. Biologics, again, can continue throughout pregnancy and breastfeeding. The small molecules, so the JAK inhibitors, Rinvoq and Xeljanz, or the S1Ps, Zeposia and Velsipity, those should not be continued during pregnancy unless there's no other option for maternal health. So we do have some patients who have continued tofacitinib, Xeljanz, and upadacitinib, Rinvoq throughout pregnancy, done well. But in animal studies, there were some birth defects and there are limited data. I just want to give the concept of looking at these medications. So the first trimester of pregnancy, particularly between weeks 2 through 8, are when the baby's organs are forming. So this is organogenesis. Any medication exposure at that time may increase the risk for birth defects. That's why small molecules, which cross the placenta during the first trimester, raise more concern. If a new monoclonal antibody or biologic, which is an antibody-based medicine, comes out tomorrow, I would feel comfortable, for the most part, continuing it throughout pregnancy because the placenta does not develop a receptor called FcRn that's needed for those antibodies to cross the placenta until around week 14, which is second trimester. And that's probably why we don't see birth defects with monoclonal antibodies, and why when a new one comes out, whether it's a biosimilar or a brand new monoclonal, we continue it. So that's the medication aspect. And I'll leave the vaccines for Dr. Dinner. Any other comments on this?
Not at all. Do you know, I'm so pleased that you said that, Dr. Mahadevan, is that, you know, although we do worry about JAK inhibitors, essentially, you know, for some patients, it might be the right decision for them to continue throughout pregnancy because they have no other alternative. And then, you know, stopping it and the risk of flare, and just, you know, just remembering that, you know, it's really difficult sometimes to get pregnant, even when you don't have other chronic diseases, and it's a precious thing. And you know, we want to try and support our patients. I think the vaccines are really interesting, and we've also had different information about vaccines over time. Certainly in IBD, so when IBD is diagnosed in adults, we ask them to get vaccinated for a number of things, you know, pneumococcus, of course, and then the flu vaccine and obviously COVID vaccine. We've not actually made any specific recommendations about what to do, you know, when people get pregnant. But I think I'm going to ask you what you would do in America. Do you continue all your vaccines throughout pregnancy, or do you actually ask patients to avoid them if they're pregnant? Dr. Mahadevan.
I'm sorry. So
what do you do about vaccines in America? Do you ask patients to take them while they're pregnant?
Yes, absolutely. Inactive vaccines. Pregnant women cannot get live vaccines, but the inactive vaccines, including Tdap, the tetanus vaccine, is very important. They give that in the third trimester. COVID vaccine, flu vaccine, all of those can be given. One issue is they check for measles, mumps, rubella before pregnancy. And if you're deficient, they recommend vaccinating you. But if you're on a biologic or small molecule, you cannot get a live vaccine. So that's important. And then for the infant, the rules have just recently changed based on data that came out of Toronto or out of Canada. So now, if you're on a biologic, small molecule, et cetera, you can get all vaccines on schedule, including rotavirus, which is a live vaccine. The only exception to that is BCG. And that's because this has all been in the UK, actually. There have been some deaths reported when infants receive BCG very early after being exposed to a biologic in utero. So it's still recommended that BCG is given after 6 months of age if they were exposed to an anti-TNF, or sooner if there's no detectable drug, which you can do a blood test for. And then some parts of the world still have oral polio, which in the United States, it's inactive polio. So if you have oral polio, which is a live vaccine, that also should be after 6 months. But rotavirus can be given on schedule.
Okay. Thank you. And I would like to highlight, there was a lot of learning from the piano registry for all what Dr. Mahadevan is sharing, and we continue to learn from that important work. One question, so in summarizing, is what I am hearing is the biologics are okay to continue. Small molecules, tofacitinib, those we have to stop unless we have no other options.
Correct.
Great. So second question is
And methotrexate.
methotrexate. Yes, thank you. And sulfasalazine, we have to increase our folic acid. So second question is, if I am a patient who's pregnant and needing endoscopic procedure or some kind of radiological procedure, what is safe? And can I go through them if needed? And how to interpret my labs when I'm looking at my lab results? Is there anything that I need to look at differently if I'm pregnant, for example, C-reactive protein, ESR, that change if I'm doing well?
Yeah. Do you want to start? I'm happy to, but if you want, go ahead.
No. I was just going to say that it's really important actually to talk about investigations when you're pregnant, because obviously we use investigations to objectify and tell us whether someone has active disease or not, or even just a new diagnosis. We find that actually a gentle flexible sigmoidoscopy is absolutely appropriate and safe to do. It's preferable not to give patients bowel prep. We wouldn't tend to give them bowel prep. We would just perhaps consider no prep at all, or even just a phosphate enema. But I think if you're trying to determine how active disease someone is and how to treat them, then that is absolutely safe. You'd also do it in the lateral positions as opposed to putting them on their back or front when you do different types of procedures, but keeping them on their sides. And from a radiological perspective, I think one of the exciting things that's happening at the minute is the use of ultrasound is starting to increase in different parts of the world. And that's considered a very safe method, of assessment, because obviously even when you're pregnant, you get ultrasounds to check the fetal, growth as such. So ultrasound is a good method, but even MRI can be used. MRIs, as far as, if we felt that somebody needed to have an MRI, we would go ahead and use, a technique that does not provide ionizing radiation. I'd be interested to know, Dr. Mahadevan, what you think from the American perspective, whether there's any other risks you think that we need to think about.
Yeah, so I think in general, the key thing is to figure out what's going on with the mom. And that always comes back to that. So yes, labs can be abnormal. The alkaline phosphatase increases in pregnancy and in breastfeeding. And the sedimentation rate can be elevated. Patients become very anemic and their albumin decreases in part because of how the volume changes in pregnancy. In terms of endoscopy, you can, if you need to, you can do an upper endoscopy, a colonoscopy, an ERCP in pregnancy per ASGE. You need to have appropriate fetal monitoring. We use propofol generally in those situations. But as Dr. Din said, a unsedated, unprepped flex sig without monitoring is probably the most common thing I do in pregnancy, because usually it's ulcerative colitis that flares in pregnancy, not Crohn's. And if you're making a change in treatment, I want to make sure. We looked at this in our UCSF population, and 11% of the time, the flex sig was normal. So we did a test because we felt that there was something going on. But remember, pregnancy causes a lot of GI symptoms. People have bleeding from hemorrhoids. And so I don't want to change medication without knowing what's going on. Radiographically, as Dr. Din said, intestinal ultrasound, if you can do that, is great. In the third trimester, it's very challenging for the technician to see the bowel because it's so crowded in there. But if you need to, a single CT scan is below the amount of radiation that's harmful, and you can do an MRI without gadolinium at any point as well. So you really have to look at what's available at your institution.
Excellent. Thank you so much. And Dr. Ali, did you want to ask anything else about medications, blood work, the piano registry?
Yes. So I think
I think we're losing you a little bit, Sabina.
When it started, how is it going?
Do you mind repeating that, Dr. Ali? I think it was breaking up.
Oh, sorry. Yeah, I would love to hear a little bit about the piano registry, and how does a patient who's interested can register and reach out, and when did it start, and how did you come about with?
Yeah. Oh, great. So thank you for bringing that up. So the piano registry stands for Pregnancy, Inflammatory Bowel Disease, and Neonatal Outcomes, and it started in 2006. 2007. And if you think back to 2007, really the only biologics out there were infliximab, and adalimumab was relatively new. And people didn't know what to do with these medications. And what was happening was that women were getting put on these medications, feeling great. And all of a sudden, people were telling them, you need to stop so that you can get pregnant. They were finally well enough to consider pregnancy, but were being told to stop this medicine. And then when they try to go back, they would get antibodies. It wouldn't work for them anymore. It was really quite tragic. And so there was a need for safety. The default is always to stop medication in pregnant women, which should not be. You're not considering the mother's health and the impact of the mother's health on the baby. And that was the impetus for the registry. And so it was a coalition of IBD centers around the United States. We enrolled people in this registry and followed them prospectively, initially for a year, then 4 years, and now we're following them out to 18 years. And there are about 2,500 women enrolled at this point. And a lot of our drug safety data comes out of it. And it also has the infrastructure to look at new drugs. So we recently published on risankizumab or Skyrizi and Rinvoq or upadacitinib. So if you live in the United States and you're pregnant, particularly on the newer medications, we would love to enroll you. No matter where you are in the US, you can enroll because it's all done remotely. And it's pianostudy.org. We also have an Instagram page and a website where you can look and say, okay, wherever you are, how many people in the study have been on Skyrizi? What recent publications have there been? And you'll see our recommendations and also some information about the global consensus on there.
Excellent. Thank you so much for sharing about the piano registry. We are getting a few questions coming in on the medications piece of things, and then we'll start to move forward a little bit in terms of other questions. So one patient has a question about biologics. I think it's about ustekinumab, specifically Stelara. If it's safe to get pregnant, is there Dr. Mahadevan, Dr. Then, in general with biologics, are there any safety signals that we need to be concerned about as patients?
So when you look at pregnancy, looking at 500 patients may not be enough. You need thousands of patients, but the signals that we have and the way the drugs work do not seem to raise concern. Remember that I said that they don't cross in the first trimester, so there's really no increased risk of birth defects, but they do cross in the third trimester. 80% of transfer of antibody occurs in the third trimester. That's how mom transfers her immunity to the baby. But because of that, these antibodies cross as well. And we've looked at that in piano, and the ones you would be more concerned about are infliximab, adalimumab, because of the increased risk of infection. And we did not really see that in piano or in large European registries. For ustekinumab, there's no increased risk of infection in the mother, and we haven't seen it in the baby. We published our piano results, and the babies actually had very good outcomes, maybe because their disease was really well controlled. There may be a role for IL-23 in the pregnancy process as well. But no, for all the IL-23s, there have not been an increased risk of bad outcomes for mother or baby.
Excellent. Thank you for sharing that. I do want to ask one other question that's come in, and it's about blood clots and IBD patients being at greater risk for blood clots. How is that being managed in pregnancy? Dr. Shahida, would you like to share a little bit about that?
Yeah, so I guess it's interesting, isn't it? So active disease in itself increases your risk of blood clots. And there's now new data to suggest that actually if you're on effective therapy that manages your inflammation, then your risk of blood clots does come down. So that's one thing to remember. But obviously when you're pregnant, the changes that happen in pregnancy can increase your risk of blood clots. The main guidelines that we follow look at patients who have active disease. So if you have active disease in the third trimester, then we do recommend anticoagulation. And I'd be interested to hear from Dr. Mahadevan, what they recommend for the first 2 trimesters. Because blood clots can be scary. There's also a consideration, and I don't think there's necessarily any consensus as to whether when somebody's had a baby, that risk of blood clot, it doesn't disappear, it's still there. So some patients actually benefit from having, anticoagulation even after birth for a short period of time, but there's no particular consensus regarding that. So, absolutely do talk about it, do consider it, and have, a discussion between both the gastroenterologist and the obstetrician as to what would be the right, treatment to give prophylactically. I mean, obviously when a blood clot happens, that has to be treated. But there's also lots of different discussions that happen around that time. But again, I'd be interested to learn from Dr. Mahadevan, at what point in someone's sort of pregnancy journey that they would consider giving, anticoagulation.
Yeah, so it's a great point. Both disease activity and pregnancy increase risk of blood clot. And so if you have both together, it can be quite significant, the increase in risk. And warfarin or Coumadin should not be given in pregnancy. We generally use low molecular weight heparin. So as with any patient with inflammatory bowel disease who's admitted to the hospital, they have increased risk of blood clot and should get prophylaxis against VTE or venous thromboembolism or blood clot. And so that generally means low molecular weight heparin, maybe compression socks. For all of our pregnant patients that are admitted for active disease, they get low molecular weight heparin. When they have their delivery, particularly if they have a C-section, they get prophylaxis or preventative therapy against blood clots. And some people go home on low molecular weight heparin depending on the C-section and their risks. And that's for all women getting a C-section that's looked at, and certainly for women with IBD. So around the time of birth, for someone who's otherwise healthy without active disease, that is a time to be concerned about blood clots.
Makes sense. Thank you for sharing some of that. I do want to move to Tanya and ask a little bit about her patient perspective, specifically around, we talked a bit about the preconception pieces, but what was your pregnancy, labor, and delivery experience like? And then what we're going to do is sort of move into understanding labor and delivery from the doctors as well.
Okay, thanks, Tina. So I had a very uneventful, smooth pregnancy and a perfect C-section. But despite that, my son developed respiratory distress when he was born, and due to meconium inhalation, and he had to be quickly moved to the NICU, and he had to be put on a ventilator. On the ventilator, he naturally picked up further infection, and every day became worse. This was attributed to my azathioprine passing into my breast milk. So that was that was probably the lowest point in my life. There was a lot of confusion back then regarding the safety of azathioprine in breastfeeding. We were getting contradictory information in the medical fraternity itself. And I was asked to stop feeding my baby. At that time, to my postnatal self, when my baby was taken away just a few minutes as soon as he was born, I think the only form of healing that I could think of for both of us was to nurse my baby back to health. So I desperately wanted to flood him with life-giving elixir, and I didn't feel like abandoning him at that point. So I talked to my gastroenterologist and discussed if we could stop my azathioprine and I could go ahead and feed the baby. We came to a consensus, and we understood that I would obviously lapse into a flare a couple of months down the road, but I could nurse my baby. And so I continued to feed my child, and he fought valiantly. And I now have a healthy 10-year-old son who's interrupts me every 2 minutes with riddles and funny accents. So that story ended well, but there was a lot of confusion and I think needless emotional trauma at that point. So that's the bit about my delivery and the complications that arose because of the confusion and lack of clarity on the drug and its safety.
Thanks so much for sharing, Tanya. I wanted to understand a little bit more about your postpartum experience. We talk a lot about getting ready for that pregnancy and having that pregnancy, and then, going through the delivery labor process. What was your experience like as an IBD mom, now having a baby at home who had some complications, of course? How were you doing in that process?
So I think the norm is healthy baby, healthy mom is like the discharge norm for hospitals. So, once that's achieved, they presume that society is going to take over and, the mom-in-law, neighbors, aunts, everyone chips in and advises the new mom on how to handle the baby. I think looking back, I found the first few months an absolute nightmare. I felt like a total failure of a mom. I had like this life with me and I was just totally dependent on me. And when I look back, I probably did have postnatal depression. I was given the emotional trauma of his birth. I was, all my hormones were all asway. That affected my emotional well-being. The lack of sleep, the exhaustion affected my IBD. And given that I was off my medication, this was a very slippery slope for me. I definitely flared up a couple of months down the road. And also the doctors were giving me some breathing space, like the gynecologists and gastroenterologists whom we were meeting almost every month during my pregnancy, sort of backed off and allowed me to, get that time with my child. But I think in retrospect, I think I needed more help. I think I should have reached out for more help. I should have known my limitations. There should have been better mental health monitoring of a mom with IBD, given the gut-brain link, and maybe a more focused care for the mother postpartum is what I would think, Tina.
So this is a really good point, and I want to turn to the doctors here. Dr. Mahadevan, Dr. Shahida, what do you normally recommend if you're seeing a patient who has now developed some postpartum depression, or what sort of checks are you doing to see if they are developing, issues with their mental health? Do you mind starting, Dr. Mahadevan?
Sure. So, so I think what Tanya is saying is really thought-provoking, because it's true. We're so focused on getting pregnant, having the baby, and then you have the baby and you're like, great, you should be happy, you're done, and it doesn't always work out that way. And there was a study out of Canada showing women with IBD may have higher rates of postpartum depression and anxiety than the general population. And the overall rate in IBD is about 20%. And so I think being cognizant of that is important, and also making patients and their families aware that this could be happening so that they can get them the help they need. It's hard to separate the fatigue of not sleeping, of all the physical things that they went through, et cetera, from the depression. And as gastroenterologists, sometimes we think, well, their primary care doctor is addressing that. And a lot of people don't have primary care doctors anymore. So it's challenging. Any medication, like the SSRIs, et cetera, are compatible with use in IBD and are things that can be given. And if someone had postpartum depression with the first pregnancy, we may continue their medication for depression and anxiety through the second one, depending on how severe it was. And so that's another thing. In our practice, we tend to see people who are doing well every 6 months, but that's a big gap between delivery and the next visit. And so that is something that perhaps we should make a more concerted effort to address. And thank you to Tanya for bringing that up.
Absolutely. Dr. Shahida, anything you'd like to add from your end?
Just to say that, I feel like we must do better. And just hearing Tanya's experience, that you're absolutely right, is that we watch you so closely, and then all of a sudden you're free. And actually, we need to be better at checking in with you, and not expecting you to have all that responsibility. We need to be better at checking in with you and just making people aware that this can happen. And sometimes I think once a woman's had a baby, it is trivialized a little bit in that they call it the baby blues. And it's not really, there are some things that will happen with, the lack of sleep, not being able to look after yourself, having a dependent. But this is, it can be more than that. And we just be careful that we don't just say it's normal, this is what to expect, because it really isn't. So, I'm so humbled that you were able to share that with us, because I think we need to do better. We need to have better ways of keeping in touch with you. After that time.
Thank you, doctors, for saying that. It means a lot to us as patients to know that our doctors care and, have this also front and center on their mind as we're trying to grow our families, right? I do want to, shift gears a little bit and talk about, so a few things that are left on our agenda. Ostomies, JPouches, and some fertility-related considerations, IVF, et cetera. With patients who've had multiple surgeries, like myself, for instance, who might be living with an ostomy or may have a JPouch now, what are some special considerations, some best practices? I'd be happy to start with Dr. Shahida and then move to Dr. Mahadevan. I did want to flag at this point, and I think we're sharing some resources in the chat. Dr. Mahadevan and I worked on a special resource from the United Ostomy Associations of America talking about pregnancy with ostomies, as well as labor and delivery, and included JPouches as well and some of the best practices. So happy to go through some of that. And Dr. Shahida, I know you've done some wonderful work looking at pregnancy outcomes in ostomy patients. So I'd love to share some of that information if you don't mind starting, Dr. Shahida.
Of course, I think it wasn't necessarily me, Tina. I think it was, a collection of people who led this work. I was just a little part of that. So I'm very, again, humbled that they asked us to be involved. But you're absolutely right. When you actually look to see what information is available that we give patients about getting pregnant, whether they have a stoma or a pouch, there's really nothing. We were surprised at the lack of this. Because we always assume there's information to share, but there really was nothing. And what the surgeons will say to the patients who have stomas is that, if you are considering having an ileorectal anastomosis or some form of pouch formation, is that, we'd recommend that you try and get pregnant while you've got your stoma. Because afterwards, there's a chance that if you get pregnant with JPouches or ileorectal anastomosis, that it might compromise, the function of the pouch, and then delivery can be, a little bit more complicated. But that's from anecdotal evidence. There isn't really any hard evidence as to what actually happens to patients with outcomes. So this study that I was, as I say, a little bit involved in, looked to see, how do patients, what time point do they get pregnant? And patients who have stomas can absolutely get pregnant. When they get pregnant, and the abdominal sort of girth increases, it does change the stoma a little bit, and bags sometimes won't fit so well and it might be uncomfortable. And often they recommend in that situation that you might want to consider, having a cesarean section as a mode of delivery, especially if in the future you're wanting to have, be having a bowel joined up again by whichever process to try and not compromise the sphincter anatomy. But I'm interested to hear what you've also found, because I don't think there's enough information there about how to help and support patients. So I'm learning from you all today about what patients want from us and what data we already have.
Dr. Mahadevan, would you like to add a little bit to that? I'm also going to add one other thing to my question is patients with fistulas, especially perianal or rectovaginal. What are you sort of recommending for, because a lot of us have those and then we end up with ostomies. So I'm just kind of curious how you're, handling labor and delivery with patients with ostomies and even JPouches.
So, first, in terms of pregnancy, if you have surgery in the pelvis, so if you remove the rectum or have an abscess, you may have scarring around your reproductive organs, which may impact your ability to get pregnant. We say, for 6 months of sort of business sex where you use the monitoring, you check your ovulation. If you're unable to conceive, then you should go see a specialist. And if you've had a lot of complex surgeries, you may need to get that testing done sooner. And what Dr. Shahida mentioned about the ileorectal, or when you have a stoma in between a JPouch, often we will ask patients to think about getting pregnant at that point if they have their partner before their rectum is removed, because at that point they haven't gone into the pelvis. And that may be a time where your fertility may be better than after the rectum is removed. And being pregnant with a stoma is you can do it. There are lots of patients who have that. One thing to remember, we tell patients this isn't the time to let yourself go. You don't want to gain an excessive amount of weight because that can be an issue with herniation. You definitely want to deliver at an institution where there is surgical backup. And NICU, and patients can have vaginal delivery with stomas, but there should be a short leash to go to C-section. And then with a JPouch, many surgeons and practices recommend C-section in part to avoid damage to the anal sphincter and increased leakage, though there is data suggesting that pouch function does not deteriorate after vaginal delivery, but none of those actually measured actual anal sphincter tone, except for one study from Feza Remzi, which did do pelvic floor testing and did find a reduction in function. So based on that, in our practice, we recommend or suggest C-section for those with a J-pouch, for those with an ostomy as well. Generally, they've had a lot of surgeries, and having a controlled delivery is a better idea. Anyone with a current or past rectovaginal fistula, we do recommend C-section. For perianal fistula, if it's active at the time of delivery, they should have a C-section, but if their perianal area is normal and that was in the past, then a vaginal delivery is certainly an option for them.
It makes plenty of sense. And I know, like, even in the research we worked on, preserving that sphincter function and also not traumatizing sort of the rectum and vagina further in some patients like myself is considered key. So speaking of myself, you all know I'm a Crohn's patient. I've had an ostomy. I've had a J-pouch for 6 years prior to having an ostomy again because of a diagnosis of UC that was changed to Crohn's later on. From multiple rectovaginal fistulae. This has been quite a journey. I'm now in my early 40s, and I sort of look back at sort of this roller coaster when it comes to, do I want kids? Do I not want kids? And where do I go from here if I've had over 20 surgeries involving my pelvis, my rectum, and now have a diagnosis of endometriosis? So it's just been kind of that journey where I've been like, can I, have a child? Can I not? And I think when I first got the J-pouch, I was told, yes, you can. Absolutely. My gynecologist did a rotation in J-pouches. She was willing to be a part of this. Then as the fistulae started developing and the diagnosis started to change from indeterminate into Crohn's, it was like, we're not too sure. And of course, this was 10, 12 years ago. So, less information, no piano registry necessarily. And I wasn't responding to the traditional anti-TNFs at the time. And with each surgery that went by, doctors started to say, we think you might have endo. We might need to put you on higher dose progesterone. How does that factor into, can we safely pull you off progesterone? Then, we started looking into seeing a reproductive endocrinologist and talking to him about, okay, can Tina take hormones? Can, we pull eggs from Tina and sperm from my husband and sort of have the zygote that, have a surrogate carry? These were all considerations that we went through, and my doctors were just concerned of the high risk of blood clots, et cetera. And so there was a lot of back and forth in my journey. And, as Tanya was talking about, the mental health, it was literally a rigmarole for me in terms of, can I not? And I think over the years, I've sort of gotten different answers. And especially with all the surgeries I've had, I've also been told there's a lot of scar tissue. And a more recent endometrial surgeon said to me, as well as colorectal surgeon, that they would have to cut through a lot of scar tissue to potentially deliver a child. And that it could result in, unfortunately, blockages for me because I already tend towards those to begin with. So I've kind of come to the decision that, it's going to be one of two things. Either I'm okay and make my peace with this, or I consider adoption. And I'm very, very happy with that decision too, because I think this is a journey. I think it's a journey of trying to figure out what's best for us. And I do want to emphasize in this talk today that, it is very much, we don't want people to feel like they have to choose childlessness. We want to make sure everyone can have their fullest life. And if they want to have children, that they absolutely can. I think for my husband and me, it's been one of those journeys where we're like, oh my God, we're so grateful Tina is still alive and here and able to do the activities that I am doing. And I think we've come to a point where we're just starting to now look into adoption. And I just want to say, it's absolutely okay to look at alternative ways of either getting pregnant, and that there's no shame in that, or looking at, more noble deeds like adoption, where children who don't have homes can get homes. So just wanted to put that out there, and turn the panel back to the doctors and our patient expert on understanding a little bit more about fertility and the different options, the alternative measures in order to consider pregnancy or even surrogacy, and what's out there. Dr. Mahadevan, and Dr. Shahida, I would like to understand some of the things that you may have talked to your patients about in terms of alternative measures of getting pregnant. Dr. Mahadevan, would you like to start us off?
Yeah, so definitely all the things that you mentioned. One thing too is a lot of patients ask about egg freezing. So I just want to mention that when they don't quite have their partner yet or their health isn't there, the IBD medications that you're on, and you can go through egg freezing based on those medications, and the process, the hormones, etc., have not been associated with flare. So there are no more side effects in the IBD patient than the patient who doesn't have IBD going through egg freezing. One thing to remember too, a lot of times in society, you see like this 50-year-old movie star having a child. Those are not her eggs, just so you know. You are meant to have children at 18, and your best eggs are used by the time you're 28. And after that, there's a decline in fertility, and nobody talks about that. So if you're interested in having a child, the earlier you do it, the better. I will have patients who are 35 say, okay, well, maybe in the next 3 to 4 years. And the answer is that's going to be a lot harder. For some people, sure. But there's also a suggestion that women with IBD have lower ovarian reserve. Their anti-Müllerian hormone may be lower than other women their age. So it's something to keep in mind. If fertility is important to you and having a child, if your health allows it, if your life allows it, if you have a partner, sooner is better than later. But there are many ways to have a family, and adoption is a great option. Remember, the process can take 2+ years. So if it's something you're even remotely thinking about, start the process of getting the paperwork and everything else done and doing the testing. And there's a lot of steps in that. So the sooner you do it, you can do it at the same time as pursuing other things. And it's hard to think about getting your disease under control and then mentally thinking about all these different ways to get pregnant when there's a lot of emotional burden and guilt and feelings of inadequacy that go with that for all women. Surrogacy is another option, very expensive. But if you can afford that, that is another way to go. So if I have some patients who've gone through so much, and the last thing we want is for their body to go through a pregnancy, which takes a huge toll on women, especially with chronic disease. And surrogacy is something to think about. So assisted reproduction, where you either have intrauterine insemination or IVF, freezing of eggs, surrogacy, adoption, all great options, many different options to have a family.
Wonderful. Thank you for sharing that. Really appreciate the open-mindedness when it comes to alternative options too. Dr. Shahida, do you want to add anything else to what Dr. Mahadevan was talking about?
No, I think they've given a really comprehensive reply, actually. And I think the earlier we have those discussions with our patients, the better hopefully the outcome that they are hoping to achieve. But there are different ways to sort of fulfill that part of your life.
I love that. That's so beautiful. I wanted to just sort of round us up, I know we're at the end of the discussion. We do have a few questions, and I know, Dr. Shahida, you do need to drop off. So I'm happy to have Dr. Mahadevan take a few questions, if that's okay. The team is sending them in. There is a question specifically on genetic testing. Dr. Mahadevan, on can you isolate any genes with Crohn's disease to sort of prevent Crohn's disease in patients? Just trying to understand a little bit more about that.
So Crohn's and ulcerative colitis are polygenetic. There are multiple genes involved, and it's not just having the genes. You have to have the right trigger to the right environmental trigger to get your immune system to malfunction. So two people can have the same genes and only one of them get inflammatory bowel disease. If you're someone who goes to 23andMe and gets testing done, you may see some genes, but remember the company also just went public. So all your genetic material is also public. So I'd be very careful about sending your genetic material anywhere. But there isn't a specific single gene that will tell you. So what are the risk factors for having a child with inflammatory bowel disease? So having a first-degree relative with inflammatory bowel disease increases risk. So for ulcerative colitis, it's about 2 to 4%. For Crohn's, it's about 5 to 8%. If both parents have IBD, the risk of the child getting it can be as high as 30%. There are also environmental factors. So great studies out of Asia from Sue Eng show high ultra-processed food and food additives can affect the maternal microbiome and increase the risk of the child getting inflammatory bowel disease. Prenatal antibiotic use may be a trigger as well. So things to think about, but from a genetic standpoint, there's no single gene or single test you can do.
Thank you so much for sharing that. In terms of wrapping up this presentation, this has been so thorough, so wonderful. Really want to thank our doctors. I know a couple of them had to drop off a little bit earlier, but I wanted to ask for some last words, some thoughts of hope, optimism that we can put out there for our patients and caregivers and the broader community. Tanya, is there anything you'd like to share with our community in terms of pregnancy, labor, delivery, postpartum, etc.?
Thanks, Tina. Thank you for having me. I think what I would love to share is that living with any chronic illness has its own challenges. I think one attitude that I've learned to imbibe to lead as full a life as possible is that there are moments in life that you need to remind yourself that you have IBD, and there are moments when you need to forget that you have IBD. If a constant reminder of my IBD while in bed trying to start a family would have been a short way of not getting pregnant. At the same time, when I was dealing with, juggling the demands of being a young mother, I think I should have prioritized my health first and reminded myself that I need extra care and extra rest. That's it. Thank you so much for having me.
Of course, and Tanya, I just want to say, it is very hard for us women to make ourselves vulnerable and speak publicly on this topic. This is a very, very personal and private topic. So thank you for coming forward from our South Asian community and speaking about this. We do understand how challenging it is, and we respect you for the work that you're doing. Dr. Mahadevan, turning to you, any sort of last words you want to share? I also want to ask you more about the piano study in terms of how can patients enroll, if you don't mind just sharing a little bit, and we will make sure that we also push out more information on the piano registry for patients to join.
Yeah, I think the mothers in the piano registry have been really amazing and very selfless in participating in it. They truly get no benefit out of it. The information that they provide is really to help future moms with IBD, and it's been invaluable. And the reason the piano study has been so successful is truly the mothers who, no matter what happened in their pregnancy, share that information with us. If you're pregnant with inflammatory bowel disease in the United States, you can email us at piano@ucsf.edu, or you can go to the Piano website, pianostudy.org, and there is a place to enroll there. But you can also look at all the information. It updates live, so whenever we enroll another patient, that's in there, as well as any papers that have come out. There's links to those as well. And especially if you're on a JAK inhibitor, an S1P, any of the newer biologics, Skyrizi, Tremfya, Omba, we really would love to have you. And we generally get the information out faster for these medications because of our infrastructure. And then in terms of for the moms, I think it's really important to find a team where whatever that is where you are that supports you. So as Tanya said, she couldn't find a gynecologist who'd take care of her because of the azathioprine. That is not what you want. You want to find somebody who understands your disease, who works with your gastroenterologist, who's understanding and supportive of you. And that may be a process that you start early before you're actually pregnant. To find someone who understands, and you want doctors who are open to knowledge and open to listening to what you have to say, because if someone comes in with fixed notions, and I still have that. For example, we recommend all pregnant women start baby aspirin at week 12 to prevent preeclampsia. And we have obstetricians who absolutely refuse and say that's not necessary when it's a very simple thing and it's evidence-based. So having somebody who's open to new information, who's willing to work with your team is really, I think, the biggest thing. And being healthy and going into your pregnancy and really avoiding misinformation. Be careful about getting information from your manicurist, your mother-in-law, the internet. It's you want to try to be as evidence-based as possible. And I will add, once the global consensus comes out, it will be on the Piano website with a patient companion, which will be in multiple different languages.
I love that. And thank you, Dr. Mahadevan. I know Dr. Din, Dr. Ali had to drop off, but I just want to thank our doctors for their dedication to women's health and, to the birthing process. I think this has been so invaluable over the last 20, 25 years. Now that we have all these new advanced therapies, it has been instrumental to understand how do we get pregnant safely and how do we carry to term safely? So this has been extraordinarily robust discussion. I very much appreciate that. I do want to share a few resources that have been shared in our Facebook Live chat. Whether it's the Piano Registry website, pianostudy.org, there's also the AGA's IBD Parenthood Project, the UOAA's pregnancy, labor, and delivery resource for ostomates and folks with JPouches, as well as Crohn's and Colitis Canada's fertility and pregnancy resource. We also have a number of patient advocates who have devoted a lot of time and energy to the fertility, pregnancy, labor, and delivery, component of IBD care, whether that's Natalie Hayden of Lights, Camera, Crohn's. I shared my story on her blog as well. Brooke Abbott of IBD Moms. IBD Moms is a nonprofit providing resources for and helping new moms. Jamie Holland of Pretty Rotten Guts, who writes about her C-section experience. Jessica Karen of Chronically Jess, who has shared quite a bit of information and has spoken at multiple conferences about the pregnancy and parenting process. Really appreciate their work. Girls with Guts has also shared a number of pregnancy-related resources and blog posts. And Michelle Pickens of Chronically Blonde has also been instrumental in sharing some of these resources in her personal journey. Thank you all for joining us today. It has been a pleasure. And we hope you will check out our IBD Desi's community. It is a support group where we can provide you with evidence-based support around this topic and many others. We thank you for joining us. Have a wonderful day.